Mr. Tan Jie-wen is a 77-year-old male who was admitted on the 1st of December 2017 with subjective fevers, pain, swelling, tenderness and warmth of his left lower limb. The patient first noticed round circumscribed lesions on his left lower limb 3 days ago. These grew into large reddish patches, but there's no pus or drainage from the affected area. There was no history of injury to the area either. His past medical history is significant for hypertension, type 2 diabetes, and asthma. He is compliant with all of his prior to admission medications, which include lisinopril 15 mg POOM for hypertension, metformin 850 PO/BD, and glipizide 5 mg POOM for type 2 diabetes. And he uses beclomethasone 200 microgram inhaler every morning and salbutamol 2 puffs inhalers Q6 hours PRN for asthma. He has no known drug allergies. He is a non-smoker, does not consume alcohol, and family history is not available. Besides the lesions on his left lower limb, review of systems is unremarkable. He appears well and vital signs are within normal limits except for fever of up to 38.9 degrees. Upon admission, the patient's labs are notable for a serum creat of 105, HbA1c 6.9%, glucose 7.5 to 8.1, white blood cell count of 13.1, AST 28 and ALT 38. Tissue culture obtained on admission so far revealed gram-positive coccus in pairs or chains. Blood cultures have no growth to date. Other labs are within normal limits. He was initiated on cefazolin 1 gram IV, Q8 hours for empiric treatment of cellulitis, and admitted to the General Medicine Service for further management. The patient's most important medical problem is cellulitis, for which he is currently receiving cefazolin 1 gram IV, Q8 hours, and Paracet 1 gram PO, Q6 hours PRN for pain. Based on subjective and objective findings, the patient's cellulitis is non-purulent and he meets 2 SIRS criteria. Thus, cefazolin is an appropriate antibiotic. However, his creatinine clearance is around 46 ml per minute. Current dosing frequency is not appropriate for treatment of cellulitis given his renal function. I would recommend adjusting cefazolin to 1 gram IV Q12 hours instead. Follow up on speciation and susceptibility of tissue culture and growth from blood culture if any. I would also streamline antibiotic coverage as needed based on culture results, and follow up on CT readings to determine the presence of deeper abscesses. In the absence of deeper infections, I may change to oral antibiotics with clinical improvements of cellulitis and afebrile for 48 hours. I will recommend at least 5 days of antibiotics and may extend if there's no significant improvement. I will continue Paracet 1 gram PO Q6 hours PRN for pain control and monitor for body temperature, white blood cell count, resolution of lesions, serum creat, LFTs, and adverse effects of cefazolin such as rash, pruritus. Treatment goals are for normalization of body temperature and white blood cell count and resolution of skin lesions. The second problem is type 2 diabetes, for which the patient is currently receiving metformin 850 PO/BD and glipizide 5 mg POOM. These are appropriate oral hypoglycemic agents for type 2 diabetes, and his type 2 diabetes is well controlled based on his glucose readings and HbA1c. However, given the plan to administer IV contrast today, metformin should be temporarily withheld. It may be restarted in 48 hours after administration of IV contrast if his serum creat remains stable at baseline. However, I will continue glipizide 5 mg POOM in the meantime. There is also the indication for primary CV prevention because he is more than 50 years old and has at least one other CV risk factor, which is hypertension. I will therefore recommend starting aspirin 100 mg POOM, and I will monitor for plasma glucose HbA1c symptoms of hypoglycemia such as tremor, diaphoresis, and adverse drug reactions, including nausea, vomiting, and hemoglobin and platelet count if aspirin is started. The treatment goals are for fasting blood glucose level of 4.4 to 7.2, postprandial glucose of less than 10, and HbA1c of less than 7%. The third problem is asthma, for which the patient is currently receiving beclomethasone 200 micrograms by inhalation (OM) and salbutamol 2 puffs by inhalation Q6 hours PRN. These are home medications which have been appropriately continued inpatient. Use of inhaled corticosteroid and rescue inhaler is appropriate for asthma, which is well controlled. I will monitor for symptomatic control of asthma based on shortness of breath and frequency of use of rescue inhaler, and adverse drug reactions such as tremor and oral candidiasis. The goal is to have no shortness of breath or wheezing and need for rescue inhaler less than 2 times per week. The last medical problem is hypertension, which the patient is on lisinopril 15 mg POOM. This is an appropriate medication for hypertension because he also has type 2 diabetes, which is a compelling indication for an ACE inhibitor. This medication has been appropriately continued inpatient. I will monitor for blood pressure, serum creat, and adverse effects of lisinopril such as cough. The goal blood pressure is less than 140/90.